grew up on a cattle ranch in southeastern Idaho. We were a long way out of town, so I grew up with animals. I don't count my brothers as truly human beings. The really fascinating thing, when I'm in the United States, people accuse me of talking Canadian. It's my choice of words, I guess, and just the diction I use. You'd probably notice a difference. The fact is that southeastern Idaho and southern Alberta, that ranching community, a huge amount of travel across that border, a huge amount of intermarriage as well. In some sense, it feels like coming home, in a very real sense, to where I grew up. I thought the best way to describe what I have to tell you today, though, is just to tell the story. So a little bit of background for me. Stumbled into medicine, largely by accident. Trained in surgery, surgical oncology. Spent some time at the National Institutes of Health in Washington, D.C. and Bethesda, really. Studying cancer. Went from there to the American College of Surgeons. We actually took responsibility for all of North America, the way we saw the world, with the Commission on Cancer, talking about ideal cancer care. I ended up, though, at the Dana-Farber Cancer Institute in Boston, Massachusetts. Picked up a degree in statistics along the way. I was over GI tumors for the Eastern Cooperative Oncology Group, so we're a big randomized controlled trial study group. 450 hospitals in North America, a few from Europe, South Africa, studying cancer therapy. So that's my real background. Had a personal experience, so I suddenly, unexpectedly became a single parent and moved back to Utah, mostly to get close to family. Otherwise, I'd be happily still out in Boston, I think. Still have my faculty appointment there at the Harvard School of Public Health. And stumbled in to a new life. Now, in describing that new life, I just thought I'd take you through what happened along the way. I hope there are a few themes that will emerge. The idea of data. Data are our ability to see what's happening around us, and it highlights a bigger role given the makeup of the group today. Given enough time, I'd like to make the argument that the key role of a physician or a nurse is as a wise counselor, a trusted advisor. When you carefully measure what most patients seek as they come into a healthcare setting, it's exactly that. It's why we're called the caring professions. I realize that as the science of medicine's advanced, more and more we emphasize curing. But the thing that made the healing profession central to human society literally across millennia has not changed. We're at our very best when we counsel with the patient, and together we can understand what healthcare choices mean. That means you have to be able to see. That's the true definition of transparency, by the way, of the alternatives laid before us. If we choose this course over this course, where does it lead? And then to execute against that. But it's the idea of a clinician as a wise counselor. If you see that idea. I hope that emerges with this. Well, the story, I showed up in Utah. I was the third person with medical training in Intermountain's leadership ranks. Intermountain is a charitable not-for-profit system. It grew out of the LDS Church's holdings. When the LDS Church decided to get out of the healthcare business, rather than selling their hospitals, a fairly substantial asset, frankly, they gave them as a gift to the community. Founded Intermountain to manage the 15 hospitals that they had at the time, scattered through the Intermountain West, Idaho, Utah. At a tertiary level, we supply services to 7 surrounding states in our system. We're about 60% of all care delivery in that region of the United States as a charitable not-for-profit system, and we actually behave that way. That's what really sets us apart compared to many other not-for-profits in the U.S. Well, I show up. I bumped into a fellow named Steve Busboom. Busboom was the vice president for finance at Intermountain. He was an accountant, finance guy. Steve had built one of the world's first activity-based costing systems. The basic idea is you measure your work at a very detailed, granular level. He was tracking every lab test that was performed. He was tracking every dose of every drug that was given, every imaging exam, acuity-adjusted hours of nursing services, acuity-adjusted minutes in a procedure room, that level of detail. Now, the truth is Steve had built that thing so he could drop an accurate bill in the U.S. financial system. That's why he had built it. But it gave you a wonderful tool to measure and manage cost. This turned out to be a huge asset to my clinical work. And not just because you could measure the true cost of care, that's essential, but at the same time, these represented clinical decisions. Well, Steve had heard about this idea of variation in practice. There was a literature that was emerging around geographic variation in practice. Everybody to that point, though, had measured hospitalization rates using insurance claims databases. The kind of poster child for the whole effort was Jack Wenberg at Dartmouth, the Dartmouth Atlas, measuring here in North America. Well, Steve wanted to push it one layer deeper. He said, we're a hospital system. I don't know much about geographic rates of utilization, he said, but I wonder if we treat patients the same when they come into our facilities. I jokingly say that more than 20 years later, Steve has finally forgiven me for what I did to his life and his idea. He made the mistake of asking a trained clinical researcher, you see, and I pointed out some defects in his approach. He was just going to use his data system. He was going to count out how many lab tests you use by specific type of lab test, how many doses of a drug, how many imaging exams, and compare physicians is what he wanted to do. Well, Steve, wait a minute. Those patients aren't all the same. I realize they were treated for the same condition, but it doesn't mean they're the same. Different comorbid illnesses on presentation to the hospital, different severity of initial symptoms. If you have a complication during your care, it will change the care that you receive. I insisted that we measure all those things and properly adjust them so that we got a cohort of patients that were identical coming in and identical coming out. Well, at one level deeper, I said, Steve, it's great, these things you're tracking in your finance system. Some of them look really interesting. Trouble is I can tell you as a physician, there are a whole bunch of things that are critical that you're not picking up, that you don't think of as a cost factor. I insisted that we form teams of physician and nursing leaders to oversee our work. Sat down with those folks and asked them, what else should we really track or cover? Well, we called them QUE studies, quality, utilization, and efficiency. Over a 2-year time period, we studied the 6 clinical areas listed, pulled all patients treated, typically within a 1-year period for one of these conditions. Then we identified and staged comorbidities on presentation, severity of presenting symptoms, every complication that occurred, individually staged those 2 long-term patient outcomes. In the quality part of the study, we formed up a group of patients that were statistically identical coming in, coming out, and we said, okay, now it's fair to look at what happened in the middle. We expanded the list of factors we tracked, roughly doubled them. First thing I'm going to show you, first thing we studied, transurethral prostatectomy, a urologic procedure. We had about 45 factors in Steve's system. We added a similar number, though we ended up with about 90 total when we got our clinicians involved. Now, these turned out to be quite expensive. In today's dollars, it would have cost about $100,000 to do one of these little studies, almost all of it in chart abstraction, to figure out what we were really seeing with the patients. What we found, though, was massive variation, truly impressive variation, far beyond what anybody expected to see. This is just an illustration. These are 2 clinical factors that our urologist has identified as critically important when doing this procedure, a transurethral prostatectomy. So 16 surgeons with statistically meaningful numbers of cases along the bottom. The little green squares show true surgical cut time. How long did you take doing the procedure, doctor? As a surgeon, I can tell you that we like to keep that short. Reduce anesthesia risk. That's what you're really thinking. If you look at the far right, physician F, 90 minutes to perform the procedure. It's physician K, who is the lowest, off to the left, 38 minutes. That's more than a 2.5 times difference in surgical times. The little red circles show how much tissue you remove. That's the purpose of the procedure, is to remove prostate tissue so that people can urinate again. That ranged from a high of 42 grams. That's physician J toward the left. Physician G, second from the right, is the low, 13 grams. That's more than a threefold difference. Oh, the thing that just stunned me as someone trained in surgery, I mean, I never would have guessed this. You can see it in the data, though. It's a very strong statistical result. The longer you operate, see how those green boxes kind of go up left to right? The less tissue you remove. See how the red circles go down left to right? Isn't that interesting? Longer times for less tissue. You see? Massive variation. Oh, the reason I display the slide, it links directly to a primary outcome we were tracking. Some patients re-obstruct their urinary system after the procedure, and you have to come in and do a second operation, repeat operation. It is associated with grams per minute. It concentrates in the three right-hand physicians on this slide. It's directly linked to an important clinical outcome. In other words, this slide, though, is the one that Busboom really liked. What this slide shows is cost per case. Now, we're fairly unique, especially compared to you. One of the few advantages I have over a Canadian system is I can accurately measure cost. Not charges, but actual cost of care on a case-by-case basis. Yeah, physician M was spending $1,134 hospital dollars to get a good outcome on a standard case. I think it was H who was the highest. Over $2,200, twice as much. Same patient, same outcome, twice as much resource going into the care. See that idea? Now, without going into the details, it turns out that this thing has some real statistical challenges. If I'm honest as a statistician, I can't tell who's good or who's bad. It has to do with sample size and what's called statistical power within these. It's entirely possible that physician M was undertreating, and because of that had a higher complication rate. I didn't have enough statistical power to pick up a higher complication rate. They're so small to begin with, you see. And so if I were honest, I couldn't tell if physician H was over-treating or physician M was under-treating. What I could honestly say, though, is, wow, you guys are different. And that's exactly what we did. We started to take these data back to our physicians to make the care transparent. Now, this was across a series of hospitals in our system, but most of these folks, I mean, there were other people in the study that were their colleagues they rubbed shoulders with every day. They respected them. And suddenly you look at those data and you realize that this respected colleague is doing it very differently from you and appears to be getting a good result. I couldn't say who was good or who was bad, but I could say you guys are really different. What is best care for a patient? Why do we do it that way? When we did that, we observed a particular phenomenon. The variation started to go away. Here's an illustration. It's the third study we did. It's total hip arthroplasty, artificial hip joints. This slide shows length of stay in the hospital. Now, this was before we started as hospitals to really work on length of stay to get the cost of care down. Today, the length of stay for this procedure would run about 4 days, 3 days, 4 days. At the time, though, when we started, it was 10 days in the hospital to do the procedure. What this slide shows is in 1988, 10 days. It falls to 7.5 days in 1989. In 1990, it's down to 7.26. Far more important, though, are those red dotted lines. They show the amount of variability. The further it is out from the center green line, the more the variability in the group of physicians. Do you notice how the variation declines? In fact, it falls to less than a third of what it was before. You see? Now, a funny thing about Intermountain has to do with the division between administration and clinical practice. Your administrators are mostly accountable for cost of care. They're managing budgets. The way I think of it is that they manage facilities using financial measures within which the other side, clinicians, treat patients. And the clinicians tend to focus on clinical outcomes. These studies were picking up both of them together, the cost outcomes and the clinical outcomes. If you see that idea. Well, yeah, they were costing a whole lot of money. And I was getting a fair bit of pushback from administration. You're going to spend how much on another one of these studies. Oh, they're fun clinical studies, they're interesting, but you're going to spend another $100,000? And then we saw this slide. This is actually the slide that changed administration at Intermountain. It wasn't just length of stay in total hips, it was a whole series of other things. As the variation narrowed, utilization per case, cost per case dropped fairly profoundly. We went from about $12,000 to perform the surgical procedure to about $8,000. That slide right there was prepared by Larry Dursteller, the Chief Financial Officer at Utah Valley Regional Medical Center in Provo, Utah. By the way, that means he had credibility with administration, credibility that I still don't have. You have to understand, I'm a physician researcher, and I can torture data to make it say anything I want. At least that's how they see it in their eyes. But Larry was one of their own. Larry was trustworthy. These were real. And suddenly my whole world shifted. It suddenly became, how fast can you do how many of these? And suddenly $100,000 compared to millions of dollars in savings, 100,000 didn't look like much. You see? Yeah, and it came from a partnership between finance, the core of administration, and clinicians is what produced it. Now, funny thing happened at this point. We'd done 6 of these. What you just saw was typical for all 6. Transurethral prostatectomies, cholecystectomies, that's gallbladder surgery. Total hip arthroplasty, artificial hip joints, the one that we're looking at right here. Number 4 was bypass graft surgery, heart surgery, to replace arterial blood flow to the heart. Number 4 was pacemakers. I'm sorry, number 5 was pacemakers. Number 6 was community-acquired pneumonia. Those are the 6 things we'd studied. And I was into a real problem. We were running out of case types where I had a sufficient volume of patients within a reasonable length of time per physician to use this methodology. After only looking at 6 things, just not enough sample size, even for this, with all of its limitations. A colleague, Dr. Paul Batalden, introduced me to a statistician in industry named W. Edwards Deming. Now, some of you may recognize that name. Deming's a physicist who is the father of quality improvement theory. And it turns out that Dr. Deming's theory described what we were seeing perfectly. Now, Deming was really in manufacturing. He was on the engineering side of the line, you see. But suddenly I had a theory that seemed to describe what we were seeing. And Deming had this crazy idea. I don't know if I can describe just how crazy it really was at that time. Remember, I was a trained academic physician. Quality means spare no expense. Quality means pull out all the stops. Quality means if it might work, let's do it. Lives are on the line. Quality means you can't talk about human lives in terms of costs. It's unethical to even talk about the resource consumption when you're talking human lives at the same time. Deming's crazy idea, he claimed that as you improve quality in most instances, it should cause your cost of operations to fall. Exactly the opposite of what I'd been so deeply indoctrinated in as a budding academic physician. And he had a plausible mechanism for it. It's based on waste theory, if you will, what he called quality waste and inefficiency waste, and they were big. Funniest thing, I came home from a meeting with Dr. Deming. Dr. John Burke at LDS Hospital, our flagship at the time, had a trial going on. He had developed data that showed when you do a surgical procedure, you're worried about bacteria getting into the surgical incision and causing an infection. They're called post-operative wound infections, and they're deadly and very expensive to treat. Major complication, any surgeon worries about them routinely. Well, John had developed data around the intervention we use to prevent deep post-op wound infections. It's called prophylactic antibiotics. The idea is I give antibiotics in conjunction with surgery before you have the infection. I'm aiming for high blood levels of this antibiotic at your moment of greater risk as a patient. That's when the knife goes through your skin. The skin protects you from a hostile external environment. That's your moment of maximum risk. So I want peak blood levels of this antibiotic so that if bacteria do enter the surgical incision, First thing those bacteria encounter is the antibiotic, which forthwith kills them, which means no infection, or at least knocks them down hard enough that the body's natural immune defenses can handle them. You see? Well, John had developed evidence that suggested that there's an ideal time at which to give prophylactic antibiotics. He had established a 2-hour time window before surgical incision and said if you deliver those antibiotics within that time window, it should reduce your infection rate. And he had a trial running to test this to see whether it would really work. Well, I go to John and I say, hey, John, this guy Deming, he's got the craziest idea. He says that as we improve quality, our costs should fall. You know, these costs, it's just another data point. So we're trained clinical researchers. We know how to measure outcomes. Of course, we always focus on clinical outcomes. We were really good at it. John, have you ever thought of tracking a cost outcome in parallel with our traditional clinical outcomes? We talked it over and decided it was a really cool idea. But John says, how are we going to get those cost data, Brent? Well, I've got this guy, Busboom. He knows how to measure cost. You see, and what we did was just take that metric cost and tossed it into the trial side by side with our traditional clinical outcomes. It was just one more number. Within 4 months, we demonstrated that as our infection rate dropped, our costs had fallen profoundly. This slide kind of shows it. Our timing of prophylaxis is the only thing that changed. We went from 40% on time to 58% by 1986. By 1991, we're up to about 96% on time. Now, that 1.8% wound infection rate in 1985 was among the very best in the United States. Joint Commission scoring guidelines said that a good hospital in North America would have a rate between 2 and 4%. And we were below the best rate and among the very best in the US. A few years later, we'd set a new standard, 0.4% infection rate, 5 times better than the best national standard. It was associated with almost $1 million in savings for the hospital because we didn't have to pay to treat the infections. And Deming was right. See that idea? We demonstrated that Dr. Deming was right when it came to clinical medicine. In fact, these were the first studies in the world that showed that principle. And they also became the heart of what's called NSQIP today, the National Surgical Quality Improvement Project, looking at patient safety factors in surgery. Published this study in January of 1991 in New England Journal of Medicine. A funny thing, by the way, we initially presented it to the journal as I've just described it, with the cost data. That was unacceptable, though, in the profession at the time. They made us scrub all the cost data out of the article. So we just reported the clinical results. And I think you know a little bit of the rest of that story, at least if you're in surgery, in clinical medicine. Uh-oh. There we go. Well, the next step happened in 1991, and this is the one, especially the clinicians in the room, I really want you to see. Context, we had a major multi-center randomized controlled trial running at our flagship LDS hospital. It had to do with a disease called Acute Respiratory Distress Syndrome. This is a disease of the lungs, deadly as it can be. What you do is put patients who develop ARDS on a mechanical ventilator in the ICU. And what we were testing was standard ventilator management for this disease versus a bunch of intensivists in Italy had developed an artificial lung, where you could place a patient on an artificial lung. It was called ECOR, extracorporeal CO2 removal, was the name of this thing. You have to have fancy medical jargon after all. Well, we'd got a big grant from the National Heart, Lung, Blood Institute to test this new Italian device, this artificial lung. And so we were putting together a randomized controlled trial. Treatment arm, the new artificial lung. Control arm, standard ventilator management for these patients. Well, we, by this point, knew to look for variation. We'd come to appreciate how variable routine practice was in every aspect. And of course, we knew that this was deadly to a trial, absolutely deadly to a trial. It's a key principle of trial design. If you don't deliver the care in the arms of your trial in a consistent fashion, you can't tell if differences in patient outcomes are due to the treatment or to the bias you introduced from inconsistent treatment. Now, because of this, we used protocols in the arms of trials. This was the first time ever that anybody had looked within a trial, though, at consistency of ventilator management. And Dr. Morris, the man who was leading the trial, he went back and measured variation, discovered huge variation in how academic intensivists set ventilators. Just in passing, this called into question all ARDS research that had been conducted at that point in time. Everybody just assumed that academic intensivists managed ventilators about the same. So Allen shows massive variation. In fact, this carried it a step further. He was able to show variation, same physician, same patient, morning to night rounds. It's kind of the ultimate in variation research. But we know how to handle that. What you do is you design a protocol, and then we hit the next set of problems. Yeah, we're going to design a protocol, but it turns out that developing protocols is rife with difficulties of their own. It turns out if you're looking for evidence for best practice, we can find evidence for best practice, even in something as scientifically well-defined as ARDS, about 15 to 25% of the time. 75 to 85% of the time, physicians and nurses can hold legitimate differences of opinion about what's best because there is no evidence. When I say no evidence, of course, level 1 evidence is randomized controlled trials. Love it when I've got that. Level 2 is strong observational designs, quasi-experiments, case control studies, case series. I'm quite happy if I have that. I'll even settle for level 3 evidence. That's expert consensus opinion using formal methods in a published form from a group of respected authorities. At a level 3 evidentiary standard, I have evidence for best practice typically less than 75% of the time. I mean, 25% I have it, 75% I don't. Problem. We don't know what works. You see, makes it hard to build a guideline, doesn't it? Number 2, most of what I rely upon is expert consensus, but a series of investigators have demonstrated that expert consensus is unreliable. Depends on who you ask and how you ask them. And you can get radically different results from different groups of experts using formal methods. And so it really even called that level of evidence into question. The next problem, we develop guidelines, and the way that we deploy them out is we train the physicians and nurses. We take them through what's called ground rounds. We publish journal articles, and then we say, okay, we've loaded this all in your head. Go apply it. Turns out there's a strong evidence base that shows that it doesn't work. Well, wait a minute. If you ask the physicians, was it useful? They'll say yes. They love it. If you say, did it change your practice? They'll say, yes, I changed. The wheels come off when you measure whether they've changed their practice. And a robust body of evidence shows that despite their protestations, their practice doesn't change. It's item number 3 on this list. The last one's the big one, though. Anybody who's practiced knows this. Well, look around the room, you can see it. Every one of us are different. I trained in surgery. If I were in your abdominal cavity, I would expect to see small anatomic differences from person to person, sometimes quite large, by the way. It's always going to be there. I have to adjust for it as I do an abdominal procedure. Part of the work, always there, you see. It goes a level deeper. You different in genetics. That means different circulating enzymes. Well, different experience too, different exposure to pathogens based upon your personal history, elements in the environment. You're going to respond differently to them because of your different anatomy and physiology, different expression of disease, different response to treatments. Every one of these are documentable, verifiable. Boy, layer on top of that differences in personal preferences, circumstances, resources. Easy case to make. Because no 2 patients are the same, you can demonstrate scientifically that no guideline perfectly fits any patient, with a few exceptions, an amazingly short list of exceptions. It's one of the things that makes medicine so complex. You see, well, we built the guideline anyway, even recognizing these differences, but that's where the magic kind of happened. The year before, a book had come out, written by a guy named Jim Womack and a long list of co-authors. It's called The Machine That Changed the World. And in it, he had described an advancement in Deming's quality theory. So the foundation for all of this is Deming's quality theory, process management theory. But Lean had carried it one step further. Lean always has 3 elements. flow, 100% participation, and what's called mass customization. Now, just a funny thing, most people doing leans seem to focus on that flow element at the expense of the other two. Bad mistake. And this is an illustration of that. In this particular instance, what Dr. Morris decided to use was the mass customization element. Remember how every patient is different? Mass customization. Now, we generalize the method. Today we call them shared baselines. Sometimes they're called bundles. Sometimes we call them protocols because they started as research protocols. Sometimes we just call them guidelines. But here's how you put one together. This is probably the most important thing I'll show you today, this slide. Number one, you identify a high priority clinical process. Number two, you build an evidence-based best practice protocol. Despite all of their limitations, despite all of their problems that I just listed, you just hammer one out anyway. You know it's imperfect. You just kind of want to be in the ballpark. It's funny, when I do it, I never ask my medical staff to approve them. It doesn't make sense. How could you improve something that by definition is not right, not perfect, right? So I just ask them, what would you change? Now this is going to make sense in just a minute. Step 3 is probably the hardest step. You blend it into clinical workflow. We use standing order sets. We use clinical flow sheets. Well, actually, I just summarized about 20 tools that have evolved over the years inside Intermountain. My aim is to make it so they happen automatically. What I know is if I rely upon the expert mind, human memory, that I'll get about 50% execution. We'll remember to do it about half the time, even with very highly trained, deeply dedicated clinical experts. And there's a strong evidence base for this, all right? What I'm doing when I blend it into clinical workflow is making it so that it happens automatically. Doctor, just let it happen, you're gonna get the evidence-based best practice. I mean, if you take the lowest energy state, don't do anything. Dog it, evidence-based best practice. Now, step 4 is important too. I embed a data system. Data systems are the key to transparency, so you can see what's happening. So here's some technical jargon. I want intermediate and final, clinical and cost outcomes. Intermediate means process steps, final means long-term patient outcomes. But I want not just the clinical results, I also want the cost results, side by side, all right? And if I embed those data systems, there's a method to do it. It turns out they have very low overhead. They're the sorts of things that clinicians have to deliver the care, but I have to embed them. Well, why is that important? It's the next 2 steps. Step 5, here's how I say it to my colleagues inside Intermountain. Here's the mass customization step. Ladies and gentlemen, doctors and nurses, it's not just that we allow or even that we encourage. We demand that you modify our evidence-based best practice protocol based upon individual patient needs. That's the mass customization step that's so central to lean. No 2 patients are the same. And that's why we have you, doctor, nurse. It's your job to determine what needs to vary for this individual and how it should vary. Oh, that's the other element in the data system at step 4. I need to track every protocol variation. Anytime somebody varies, I need to know that they varied. And the second half of that data system, I need to know what happened around the variance. See that idea? That establishes the framework for step number 6. I feed those data back. Within lean, it's called a lean learning loop. So there's a mouthful of jargon. I take that team and then feed the data back to them in a loop. What it means is my protocols tend to evolve over time. Can I show you one just really quickly? This was ARDS. They tried this. Patient number 1 that they used it on, patient number 29 in the series of ventilated ARDS patients they were tracking, that expert team in an academic center followed 41% of the protocol recommendations. More than half the time, 59% of the time they varied. But then Alan started that feedback loop running. It took him 8 patients across 4 months before they first went over 90% compliance. Oh, big takeaway. During that time period, they put more than 125 changes into the guideline. What I've come to understand is that there's a difference between theory and reality. There's a difference between sitting around a conference table to develop a kind of a theory-based practice guideline and actually being at the bedside in a real clinical environment. And that's what you're seeing on this slide. Every protocol we've ever developed shows this very rapid rate of change initially as you adjust theory to reality. The second thing you'll notice, count for me the number of patients where they followed 100% of the guideline instructions. Oh, it's 0. A demonstration of a principle. Oh, by the way, this protocol is used across what's called ARDSNet, 16 big academic centers that study this disease together. There are more than 100 big ICUs, level 1 trauma units, who use the same protocol. We have thousands of patients through this thing. At least to date, there has not been a single case where we've been able to follow 100% of the guideline recommendations. Humans that come to us for care vary, and you have to adjust. Lean mass customization. See that idea? It did have some impact. Survival rates for the patients in the trial, the most seriously ill patients with ARDS, improved from 9.5% to 44%. More than a 450% improvement in survival for this very deadly disease. First time since ARDS was defined as a syndrome in the 60s that anybody had shown an improvement in clinical outcome. And it came from a clinical group, 8 intensivists, their nurses, their respiratory therapists, coming together as a team and developing a standard approach to ARDS around which they could vary based on individual need. A massive improvement in clinical outcomes. Interestingly, costs fell from about $160,000 per case to about $120,000 per case, about a 25% drop in cost. By that point, it's exactly what I expected. Deming got it right. Nearly always, best care is cheaper care, compared to the alternative, at least. Oh, interestingly, physician time fell by about 50% to manage these complex cases. It's associated with massive improvements in clinical productivity. The reason is those physicians didn't have to bird dog every little step. They had come together as a group and agreed upon a common approach. It's what we call reliable systems. It means that if you just let it happen, you could count on it. We're measuring it, we were managing it together as a group. And you got to focus your time and attention on that subpart of a patient's care who really needed that level of expertise. The fun part of medicine, frankly. The productive part of medicine. I'll tell you as physicians, for those who are physicians in the room, you try this for a while and you start to wonder why you'd ever do it any other way. Seriously. It just resonates. You want to hear the really crazy thing? I learned this as a surgical resident. When I was in the middle of a case, I expected to reach my hand back and have my nurse slap the right instrument in my hand without a word being said, because I did every case the same every way. It was just good practice. You see? Made me faster. I didn't forget things. Oh, and if something went seriously south, if I encountered a problem, I knew everything was, and sometimes it was life or death around those things. That was drummed into my soul as a surgical resident. And Dr. Deming and Lean, Jim Womack, gave me the theory to describe what we were doing for all those years and make real sense out of it at that level. I've watched my colleagues in internal medicine do the same thing. They have a standard diagnostic workup. Faster, you don't forget things, right? And then you vary around that common shared baseline based on individual need. Now, in passing, this is the opposite of cookbook medicine. The absolute opposite. It's the guideline as a management tool that takes advantage of your most important resource, the trained expert mind. It requires an embedded data system to actually manage the care at a clinical level. And that data system at the same time creates true transparency. So when I sit down with my patients to say, here are your treatment alternatives for your disease. If we do this one, this is what you'll get. If we do this one, this is what will happen. If you do this one, this is what will happen. So that working together with my patient, that patient can make best decisions for their own life. See that idea? That's true transparency. Right there. Well, yeah. Key takeaways. No protocol perfectly fits any patient. The solution, shared baseline bundles. A way for a clinical team to come together. There are very serious limitations to protocol development, and we recognize these days. The solution, a lean learning system with that feedback loop and the embedded data. A third problem, reliance on human memory produces about 55% execution levels. Strong evidence base for this. I can get it up to very close to 100% by embedding those clinical workflows and asking my most important resource, trained expert mind, to focus on variation, not on scut work, not on the routine. manage the routine as a group, manage the variations as an expert. You see the idea. Now, the funny thing, it just requires one new idea. The idea that I can't stand on my soapbox and say, in my experience. You know, when I was practicing surgery, I expected the residents to do it my way. Right? I understood that the other surgeons did it differently, but when they were on my cases, they got to do it my way. I expected the nurses to do it my way. Administrators, shut up. You don't even get to say a word, just give me the resources and get out of the way. It's kind of the attitude I had. I bet you see that too sometimes here. The one I'm least proud of, I expected the patients to do it my way too if they kind of wanted the magic in these hands. You see that idea? Well, what if we came together around a shared work process as a team and built a reliable system that supported me as an expert? So I could take my most important resource, that trained expert mind. I have to choose what varies and how they vary to optimize for an individual patient. That's the idea of mass customization. Now, the thing you need to know, yeah, it should have started in medicine. There's nothing new here. But more important, it works. It works on a broad scale. Can I show you a recent one? Turns out the main source of death in North American hospitals today is sepsis, body-wide infection. Within a typical hospital, acute care hospital, more than half of those cases will enter the hospital through the emergency department. Patients will have developed that infection in an outpatient setting, but they're kind of tricky to detect. Two of our leaders, Dr. Todd Allen in the emergency room, Dr. Terry Clemmer in the ICU, got together and built a shared baseline bundle for sepsis, outpatient sepsis coming into the hospital. It's a fairly complex thing. It has 13 steps in it. We're trying to simplify it down to 4 to make it easier to deploy. These are data from our 4 largest hospitals. The yellow line shows overall compliance over time. Started back in January of 2007, about 30% compliance with the elements of the bundle. Now it runs typically about 90%. It's never 100%, by the way. Now, mortality rate for this condition, at least down in the US, ranges between about 20 and 50%. This is a deadly, deadly disease. When we started, we were among the best in the US. We had a 20.2% mortality rate with research quality tracking systems. I checked before coming. In the last 3 years, it's never gone above 6%. Now, that's about another 125 lives per year. 125 people who didn't die, who would have. Here's the big takeaway, lesson number 1. I have more than 100 of these. I can document more than 1,000 lives per year in the Intermountain system of people who would have died, who didn't. We count our successes in lives. And as you well understand, that's really the tip of the iceberg, isn't it? This idea. Really the tip of the iceberg. For every life that we save, a far bigger impact in terms of suffering avoided, function restored, lives repaired and put back on track. In this work, we count our successes in lives. And I have the data to prove it. Now, second thing behind it, I can best illustrate with another little case study. Turns out the biggest single process that we operate inside Intermountain is pregnancy, labor, and delivery. We deliver about 34,000 children per year within our system. It's 11% of our total system volume. It's the biggest single thing we do. We have a maternal fetal medicine doctor, Brian Oshiro, who is leading our women's and newborn clinical program. You see, we organize around clinical care, not just around hospital departments. We organize around clinical processes within Intermountain. And Brian owned big old number 1, pregnancy, labor, and delivery. Turns out there's a body of data in the published literature that talk about something called elective induction. We have drugs, chemicals, that can put a woman into labor at the end of a pregnancy. Full-term delivery is 40 weeks gestational age. But end of pregnancy is uncomfortable for the women, and the physicians like to be able to schedule their day. It's not just convenience. It's that you have an established relationship, and you'd like to have this delivery happen while you're on call so that you could actually attend the delivery. And what emerges from that, a woman will show up and say, I'd sure like to get this baby delivered. Well, ma'am, if you don't go spontaneous into labor, next Tuesday I'm on call, it's a good day for me. Just show up at the hospital, tell them I sent you. They do this all the time. They'll admit you to the hospital, they'll start an IV, they'll start a drug called oxytocin, Pitocin. It'll cause your body to go into labor and we'll get this baby delivered. The trouble is the evidence shows that if you do that before 39 weeks gestational age, it's associated with increased rates of harm to the newborn. It's reflected in newborn ICU admission rates. So at 38 weeks, you get about a 50% increase in NICU admit rates. At 37 weeks, you get a tripling of NICU admit rates. Now, transparency, I remember we first showed this to a room full of our obstetricians, family medicine docs. We have a certain number of certified nurse midwives in our system too. We got a typical physician reaction. They looked at it and said, well, Brian, thinking back, I can't remember a case where an early elective induction put a child in a NICU. Well, wait a minute, in Intermountain I have that transparency. I have the data systems, would build them. Took my statistician assigned to the team, Eric Henry, about 20 minutes to run our own data. You're looking at our own data. It replicates the national data, and there was a profound shift in conversation. I mean, it went from being, I don't think we have a problem, to this looks like something we should work on, across a group of almost all community-based physicians, just by having that transparency. Well, we had to make a change in workflow, so here's a really simple protocol. Turns out the American College of Obstetrics and Gynecology has done an evidence review and published a list of criteria for appropriate elective induction. Now that word elective is key here. Some inductions are medically indicated. You have to do them for the health of the mother or the child. These are elective where it's purely convenience and scheduling. All right? So you have some choice. That's the vast majority of inductions, just in passing. Yeah, old process, the physician would say, go to the hospital, they'll check in and get started. New process, we just added one step in the workflow. The woman shows up and says, my obstetrician sent me. The nurses would say, well, before we can admit you, we've got to run the ACOG criteria. 9 factors, the big one is gestational age, and they just go through the criteria. If the woman was not an ideal candidate for elective induction by professional standards, there was a phone call back to the obstetrician saying, doctor, your patient doesn't meet criteria for appropriate elective induction. You need a consult from maternal fetal medicine or from the department chair before we will proceed. That was a change in process. This shows inappropriate elective induction rates when we did that. It went from 28% initially down to 6%. Today it runs about 3%. Now wait a minute, 3%. When you look at the cases that happen, they are weird. I don't know how else to describe it. They're strange. You get these strange cases that don't fit the criteria very well. I actually think we're close to perfect on this one, when you take into account the fact that no guideline perfectly fits any patient. You see. Now, the obstetricians and certified nurse midwives and family medicine people in our system who do this process liked it well enough. The next year they added another factor. It's called a Bishop score. It's a 4-part physical exam that measures whether the woman's body is ready to deliver. There are changes that happen at the end of pregnancy that make it really easy to deliver versus hard to deliver. All right? And this is a measure of them. Bishop score of 10 or higher is the professional criterion. This is just to show you what happens with Bishop score. Now 10 or higher, see down there on the x-axis where it's at 10, the yellow bars are first deliveries, so hard delivery, what we call primiparous deliveries. The blue bars are second, third, fourth. They're called multiparous deliveries. Each of these effects is statistically significant. What you're seeing is unplanned C-section rates. At a Bishop score of 10 in primips, we had a 5.8% unplanned C-section rate. Well, just come back to a Bishop score of 7, it triples. Come back to a Bishop score of 2 or 3, it goes up by a factor of 6. And by the way, when you do a C-section on a first delivery, you probably just committed that woman to C-sections for the rest of her reproductive history. A C-section, of course, is a surgical procedure. It will more than double the cost of care. Well, what they did was just add Bishop score, right there side by side with the ACOG criteria. The most important thing in this slide is that blue line. It shows among first deliveries a proportion of cases that were inappropriately electively induced, either on the basis of ACOG criteria or Bishop's score. It goes from about 15% of all first deliveries. Well, today it runs under 1. Again, I can't write a protocol that perfectly fits any patient. Now, this thing turned out to have some impacts. The first is that, Bishop's score is associated with time in labor. We took about 45,000 minutes out of labor. Time in labor. Labor is really expensive, just in passing. 1 nurse to 2 patients. Very intense resource environment. Means we can deliver about 1,200 more children per year without adding a single additional nurse or a single additional bed. So you leverage your fixed resources much more heavily. Second thing, the reason that Intermountain in the U.S. runs about a 20% overall C-section rate, while the U.S. as a whole is at about 35%, is that little protocol. We recently estimated that this saves people in the state of Utah about $50 million per year in healthcare costs, with arguably a better clinical result by deploying this protocol system-wide. Lesson number 2, nearly always better care is cheaper care. You see the mechanism for it? You see what's happening here? Well, as we started to see this, we started to deploy it across our entire system in a very broad, consistent way. Can I show you just one more quick example? This happened down at one of our little community-level hospitals. It's American Fork, Utah. It's about 25 miles south of Salt Lake City. Young community, very, very active birthing service at American Fork. Dr. Terry Melendez in obstetrics led this effort. Turns out that when you have that many deliveries, you're going to have some children that are almost full term but not quite. They're not really preemies. That'd be under 33 weeks gestational age, but they're a little early, 33 to 37 weeks. Turns out American Fork gets about 110 of these kids per year. Now, the last organ system to mature in a developing neonate are the lungs. That's the last one to finish off so you can be born. And what happens with these children, many of them suffer from something called respiratory distress syndrome. Their lungs lack structural integrity. And at the end of each breath, the lungs collapse. And it means these children can't oxygenate. They're blue babies, and they die. Just in passing. Well, wait a minute, they die unless you intervene. Intervention, traditionally, we would intubate them, put them on a mechanical ventilator, stick them in the newborn ICU. It's not just that you can inflate the lungs with pressure to get oxygen in their blood so that they do well. That lung collapse damages the tissue. And so these kids tend to spend about a week to 2 weeks in the NICU. They do really well. They tend to get a really good clinical outcome, but it's fairly expensive, as we'll see in a moment. Well, how to say it? Their mothers cry a lot when they see what we do to their babies. On the other hand, it's better than dying. You see, it's kind of tough love in terms of what you do in an intensive care unit to a human being. Well, the folks at American Fork in OB got to working with the people in the NICU looking at this process of care, and they had a bright idea. It's called nasal continuous positive airway pressure, NCPAP. Have you seen those sleep apnea machines that we plug on people who snore? It plugs into your nose and blows positive pressure up into your nasopharynx and then from there down into your lungs. Same thing. Turns out this technology has been used in newborns for several decades and it's safe. And they said, these kids are almost mature. I wonder if that would be sufficient to overcome their RDS, the respiratory distress syndrome. I wonder if it'd be sufficient. Some NCPAP, a little bit of oxygen. We use a drug called surfactant to reduce surface tension in the lung. And we ran a trial. And it turned out it worked. As you can see on the slide, the third bullet down, the proportion of children intubated in the NICU fell from 78% of these kids to 18%. Now, in case you missed it, that is a much better clinical outcome. And then Terry and Steve Minton, the neonatologist who led this, came back to me and said, Brent, what financial impact did we have? So I measured financial impact. And now I'm going to jump ahead on the finances a bit. What matters to a hospital administrator is something called operating margin. You have to balance a budget in the end. Operating margin is the difference between your expensive care, true expensive care, and how much you receive to deliver the care. If a hospital, a not-for-profit hospital here in Canada, down in Intermountain, doesn't have about a 3% operating margin, you will die. You have to have a certain amount of resources to capital, to replace buildings, to replace equipment, to grow based upon community need, these sorts of things. And usually it's estimated to be roughly, it's not a clear measure, about 3%. As you drop below that, you're in the death zone. It's just a question of how fast you die. The further you get down, the faster you die, you see. So I measured operating margins because that's what we hold our administrators accountable to for the financial survival of our system. Well, at American Fork, the birth hospital, they had about a $470,000 increase in operating margin on these 110 kids per year. I mean, they just stayed in the hospital for about 2 weeks on NCPAP. It's funny, they called it a level 1 NICU, newborn ICU. Looks like a nursery to me. But off in one room, they have a bunch of kids and warmers and a little machine plugged onto their head, and they do really well. Not nearly so traumatic. Now, we pay for transport to transport them to the NICU. Independent service supplies the ambulances. But it means I have to have nurses on call. In the before state, we got paid when those nurses were used. In the after state, they're on call and we pay them, they don't get used, so we don't get paid. We took about a $50,000 margin hit for transport. The big hit was at our newborn ICU at Utah Valley. We own that one too. Yeah, the cost of care declined dramatically, but their operating margin for this class of kids fell by about $750,000 per year. They were using this service to keep the hospital alive. It was one of the things they used. You know, a lot of what we do has negative margins, and you have to have a few with positive margins to make things balance out. That's what happens in a real hospital. And that to Intermountain, we took a $330,000 margin hit. Now, we know what was paid for the care. We're mostly an insurance setting. So I went back, I could tell to the penny who paid us what for the care. The insurers in the state had $870,000 of reduced health care costs, far in excess of what we lost. But what's wrong with this picture? The problem is the people who led the change, who made it happen, right, had the idea, tested it, proved it, implemented it. There's a fair bit of work involved in all of this. We were financially punished as our cost of operations dropped, and the payers got a windfall savings. See the problem? I mean, we're committed to this as Intermountain. We're a charitable not-for-profit. We're kind of like the Canadian system. In fact, what we did is we then deployed it system-wide. It was a better clinical outcome, and we turned a $330,000 margin hit into about a $5 million margin hit, and we had to go scrape up that money from other places. I have watched the same thing happen in hospitals in Canada. The more common mechanism, somebody will lead a beautiful improvement effort, reduce cost of operations, and I've watched political leadership in the health system take those savings and transfer them from the group who did well to another hospital that's doing poorly, who's doing the opposite in terms of leadership in high-quality, low-cost care. Happens routinely. And I can't count the times that I've had strong clinical administrative leaders in Canadian hospitals tell me, I'll never do that again. What happens is you're punished for your goodness. No good deed goes unpunished. So the implication, it's now finally happening in the U.S. I think you'd have to come up with your own version of this. Current U.S. payment mechanisms actively incent overutilization. I'm paid more to do more. I'm given more budget if I harm my patients. I have to have money to treat the complications. See that idea? It actively disincents innovation because I lose the money that I have to invest to do the next project. I have no margin upon which to do the next project. And the evidence for this is extremely strong, wide, and deep. It's easiest to see in the U.S. system, but I think you also see it up here as well. Slightly different mechanisms. But I hope I'm outlining for you what the solution might look like. By the way, that's what's happening for us. You'll hear a lot about accountable care organizations down in the U.S., accountable medical homes, bundled payment, shared savings models, pay for value. These sorts of mechanisms. What they're all doing is aligning the financial incentives to the care improvement. What you do is you put the care providers at financial risk, but you structure it so that if they improve care, a better medical result, and it causes a drop in costs, that they can retain some portion of that money to keep their institution alive and to do the next set of projects. As you strive to create a learning system that can deliver ideal care, the way we say it inside Intermountain, the short version of our mission statement, the best medical experience at the lowest necessary cost. You see, as we do that, it means that our services are available to a wider array of people. The queues disappear. People get service when they need it, exactly how they need it. That's the idea behind it. See that idea? And it works. It works. So we're in the midst of a fundamental shift, at least in the US. In the past, we focused on top-line revenue enhancement. How do I expand the budget for what I'm doing? How do I get paid more? Where quality is defined by regulatory compliance. What's happening to us in the future, quality becomes a core business. Quality is the way you make those budgets. Best clinical result drives the lowest necessary cost. And it means you shift from top-line revenue control, arguing about how big my budget is, to bottom-line cost control. That's the idea behind it. And that's what we see happening. Now, just one last idea. Some years ago, I participated on an IOM panel that produced a report called Crossing the Quality Chasm. The title comes from the second paragraph of the introduction. We've done an evidence review, and we showed that in modern Western medicine, between the quality we could have and the quality we do have lies not just a gap, but a chasm. We could be much better for our patients in their hour of greatest need. Well, yeah, it came to be called the triple aim. How do I create a system that gets the best medical results at the lowest necessary cost at a population level and the best experience of care along the way? Well, it turns out that quality improvement is the science of process management. And when you focus on processes, it forces you to something called Continuum of Care, where you start to think about these disease processes from before their inception as they occur, down through their entire care over time until they finally resolve, hopefully with a good solution, not with death. But it's called Continuum. It means that you organize your health care not around the building, the hospital, let's say, or the clinic, not around the technology, not around the superstar physicians. You organize around the patient. Now, the jargon we use for that in Crossing the Quality Chasm is patient-centered care. So think of patient-centeredness having two meanings. The first is that you involve patients actively in the conversation at every step along the way. You put them on your committees, right? You get that voice of your ultimate customer deeply engaged. But there's another level of patient-centeredness where you organize the system around patients. If you start to do process management, it will force that. It's unavoidable. It forces you into continuum. Continuum is another word for process. You see? Now, if you get to that level where you have patient-centered care, both ways, if you then put the care delivery system at financial risk, it forces you to population-level care. The key operative mechanism of waste and quality improvement is the idea of prevention generalized. The jargon we use for it is move upstream. Rather than running a process where you wait for a failure, that patient to develop diabetes, then to need hospitalization for their diabetes, what if I moved upstream in the process, modified it so that the patient never developed diabetes, never had to be hospitalized? See the idea? That turns out to be where most of the cost savings come from, this idea of prevention. Yeah, if you combine patient-centered care with various levels of provider at financial risk, it forces you to population-level care and the triple aim. It's unavoidable. Now, I think I realize who I'm talking to. I have a deep appreciation for the philosophy, not just the mechanism, but the philosophy that underlies the Canadian healthcare system, and I understand why many of you value it very deeply compared to something like the US system. Makes sense to me, given the nature of Intermountain. It's a service mission to care for each other. You see? Makes a world of sense. In some sense, you're by definition a population level system, aren't you? I'm showing you the mechanisms to be a more effective population level system. I would argue, I know this for Intermountain, but I think it may be true for you. We could be much better for those individuals who seek our help, sometimes in their greatest times of challenge in their lives, when lives are on the line. We could be much better. And if we do it wisely and well, it's not just that we will be much better in terms of clinical results and experience of care. We will also do it at a cost that makes our services available to the entire population, deeply and broadly. That's the goal, right there. We have mechanisms to make that happen. You have the philosophy, build the system. And together, let's learn just how good we can be for the people we serve in their hour of greatest need. With that, let me say thanks for your time and attention.